You know what? Who's smarter? Who's smart? Your patient is as smart as you teach them. Oh my God. The ultimate goal is to change that hemoglobin A1C to be within that parameter. What's that parameter? We want to see that hemoglobin A1C.
Oh, that's the 6.
We want to see
0 to 6.0.
We want this hemoglobin level to be between that 4.0 and 6.0. We want to see the fasting glucose to be between 70 and 110. That is the reason why we would give these meds, right? That's the evaluation. We take a blood sugar check every day. And let me tell you what, if you check a patient's blood sugar every day and you do it at the end of their finger, you're going to kill them. This is where all the nerve endings are. And you know what happens when you hit a nerve ending? It doesn't take a joke. It starts getting numb. And you can actually contribute to more diabetic neuropathy. So make sure that you do a finger stick and you do it on the side of the finger. I really want to leave at 2:30. I don't have to, but we need to cover everything. I have 22 slides and I could probably do that in 20 minutes. So it's going to make us like at 2:40. I don't have to leave exactly 2:30 as I had originally thought. Okay, so I'm gonna continue. Okay, I'm gonna continue. All right, so now we need to talk about insulins. And if you look on your drug classification sheet, this matches your book. And when we talk about these insulins, there's also great pictures in here about the insulin needles and the insulin pens. If you have a patient that is wearing an insulin pump and the patient experiences a hypoglycemic episode, the best thing that you can do for that patient is to take the needle out of them. Don't even worry about working with their pump, because obviously there's so many pumps out there. We cannot be educated to them all. They're coming out new every day. And you could potentially bolus your patient with insulin and make the problem worse. So if you have a patient that has an insulin pump and they go into a hypoglycemic episode, you just remove the needle. Simple. You know how to give an insulin pen injection, right? Okay. You prime it. You clean the hub with alcohol. You prime it to 2 units. You push the 2 units through, and then you dial your dose, because you have to make sure that the insulin comes out through the needle. We have rapid and short-acting insulin. Because if you see on your sheet, you're going to see that there's a list of rapid and short. And what I've done on your sheet is I've taken out the insulins that we're concentrating on. Because in your book, you have a lot more listed. But I just pulled out of your book and put on this paper exactly what I want you to focus on. Okay? And notice that there's a little memo down here at the bottom that's bolded next to an asterisk mark, and it says logs fall rapidly. So when you look at this paper and you see here that insulin lispro is also known as Humalog, that ends in log. And if you look at the type of insulin that it is, it says it's rapid, which means it gets into the body within 15 minutes of being injected subcutaneously. It starts peaking its best work at 0.5 to 1.5 hours later. And it lasts for 5 hours. So when we give rapid insulin, it causes the blood sugar to fall rapidly. Does that make sense? Why the logs fall rapidly? So when I say, oh, Humalog, Lispro, you should immediately know, oh, it's a rapid acting insulin. Now, short acting insulins are Humulin R, for example. So they have an onset of 0.5 hours, which means 30 minutes. So they're a little bit slower than the rapid acting insulin when it comes to starting to act, right? They have a peak of 2 to 4 hours, and they last for 5 to 7 hours. So what you're seeing is on the MAR, you're seeing a sliding scale. Does that ring a bell to you? A sliding scale insulin order? I wanted to bring that one up. I don't know if I can. We give rapid acting insulins right before meals or short acting insulins. I didn't spell it right either. Okay, so here's a MAR, for example, and you have a sliding scale. So do you see how this is? We check the blood sugar, and then whatever the result of the blood sugar is, we're going to give a rapid acting insulin. It's going to help bring down the blood sugar. And then, if you look at the rest of your sheet, you're going to see Humulin N and NPH interchangeably mean the same thing. Those have an onset, they start working within 1.5 hours. They peak 4 to 12, and they last for 16 to 24. This insulin, Humulin N or NPH, is cloudy. I don't know if you remember that from the lab. It's cloudy insulin. So you don't shake it when you pick it up, but you just roll it gently between your hands just to kind of mix up the solution. It's the only insulin that's cloudy. Humulin N and NPH is the only insulin that's intermediate, which means that it doesn't act fast, but it kind of has an extended release effect. Does that make sense? When you look at Levemir and Lantus, those both start with L. Those are long-acting insulins. So your insulins that start with L are long-acting, which means that they start within, Levemir starts within 1 hour. Lantus, 2 to 4 hours. The peak for Levemir is 6 to 8 hours. Lantus doesn't have a peak. That's the difference between these two. Lantus is more of that long-acting continuous medicine. And so it'll last for 24 hours. And then your Levemir will also last for 24 hours. The Humulin N and NPH. Your intermediate insulins are the only ones that are cloudy that need to be gently rolled between the hands before you mix or before you draw it up. So if you ever look at that syringe, and you see it here in your book, that it has the ability to hold 100 units, and the other one has the ability to hold 50 units. If you come to me and you tell me that your patient needs to have 80 units of insulin, I tell you, look at that syringe and tell me if that isn't a big dose. It's a big dose. Ideally, we see patients prescribed insulin about 50 units or less. Now, when I say that, I'm talking about NPH or Humulin N or Levemir or Lantus. When it comes to your rapid or short-acting insulins, the max that they usually are prescribed is about 20 units. Because it causes the blood sugar to fall quickly. If you have a patient that has more units than that they're taking of Humalog, then that should tell you how bad their diabetes is. Mm-hmm. Yep. Yes.
So is it the human age that you grew between the hands?
Roll.
The roll.
Yeah. That you roll gently.
That's the only one.
That's the only one. Yep. It's the only one. Mm-hmm.
Human.
Mm-hmm. Mm-hmm. So the thing of it is with insulins, quite honestly, we have to make sure that we get them rotated and we have to document the site that we rotated. So look at the documenting tool that you're using to verify how you should be documenting that. First of all, when you open up insulin, make sure that you label it as far as the date and your initials, because it's supposed to be open no more than 30 days. I already told you about the insulin pump. And so insulin, what is the biggest side effect? Hypoglycemia. And if you think about hypoglycemia, what are all the symptoms there? Nausea, physical weakness, sweating. I mean, it could be a lot of things. Okay. What is it that we're trying to achieve when we give insulin to make sure that the blood glucose and the hemoglobin A1C go within that normal range? That's our aim. And then, so do you recognize hypoglycemia? Right? What do you do about it? Like I said, ask the facility about their protocol. Usually if your patient's coherent, you get them to drink orange juice, but the orange juice will bring their blood sugar up and it'll cause it to fall really quick later. You have to give them proteins and carbs with that so that it stabilizes. Does that make sense?
So what is glucagon here?
So glucagon is just glucose. That's it. You've got to get them to sit up to the table and eat a sandwich.
They give it to you in a squirt and like
So they do have it in liquid that you can put sublingual. They make it tablets. Patients that take insulin, we tell them, carry peppermints or some type of sugar. Yeah, and they make glucose tablets too for you to suck on. So if your patient cannot follow instructions to eat, then you give them either sublingual glucagon or you give them an IM injection of glucagon. Do you remember how fast an IM injection starts working? That's IV. That's IV. Okay, we're getting somewhere close. 10. 10. Remember when you go get the COVID vaccine, they tell you sit down for 15 minutes because it takes 10 minutes for this to work? How quickly you've forgotten. Come on. That's what I said too. Shame on you guys. But just remember, if you have to do this, you're going to have to wait 10 minutes. You got to do some other stuff. All right. Urinary system. BPH is what we're going to start talking about. Benign prostatic hyperplasia. All right. So men who have prostate glands, especially when they get older, they begin to develop some edema in that prostate gland. It's triggered sometimes by genetics, hereditary. It could be too much sexual activity. There's a number of things. Yeah, for sure. So I can tell you that there is this over-the-counter medicine that men like to buy, and you're not going to believe what it's called, but it's called cat's claw. Yep. And yeah. And then the Dollar Tree, because men that have BPH sometimes have sexual dysfunction too. So there's a medicine, and I can't remember what it's called, but they sell at the Dollar Tree. It's for $1. It's 30 tablets for $1. It's supposed to invigorate the sexual arousement. So I see men buy that stuff too, and I for love me. It's a brown and speckled tablet, but it's something. Yeah. So you have to be careful, because as these men start buying things over the counter and they start doing lab values, which I don't have PSA on your sheets, but I'm going to need to add that because your book now talks about PSA. They'll look at homeopathic remedies before they do prescription meds. So here's a DHT, a dihydrotestosterone inhibitor. So this helps to relax the prostate gland. Actually, this medicine is an alpha-1 adrenergic blocker. It was originally made for hypertension. And what they found is it doesn't do a whole lot for that. What they found is, through trial and error of administration, that it best helps with men who have BPH. Because it relaxes the prostate, but you know what? They give it to women too. And it does. For those patients that have urinary retention, and men that have BPH, they have urinary retention. You give them this med, they're, you know, like Wellbutrin. Wellbutrin is an antidepressant. But they found, and we're in chapter 9 now, what they found is that it helps to alleviate or suppress smoking. So they prescribe that more than they do for depression now, for smoking cessation. So dutasteride, also known as Atavert or finasteride, very frequently as a Proscar. So this medicine is like an anti-nuclear type of medicine. So if you're childbearing or trying to become pregnant, you shouldn't be handling this medicine with your bare hands. You should be handling it with nitrate gloves. Now, some of you are CMTs, you work in long-term care, and you're like, that's the first I'm hearing about it. Well, let me tell you this. I've never lived in the perfect world that everything was labeled the way that it should be. And this is one of them that's not. Yes. Anti-neoplastic agent. Yes. As a chemotherapy drug. Yes. Because it's very harmful to women who are pregnant that have an unborn child, gestation. But see, this is just it. I've taken students to long-term care. We're sitting there at the cart. We're going to pass meds. And I just randomly say, what's this drug? And the student says, I don't know. And you're going to touch it? I don't think you're not. Because I already know what the drug is by looking at it. The student doesn't. She looks it up and she says, well, it's an anti-neoplastic agent. Oh, really? You're going to handle that with your hands? A woman who's never had children before. But see, if you don't know what you're doing, what you could do to yourself. Because in long-term care, they don't label everything like they do in hospitals. It's almost like you're the stepchild. What's that? Yes. And so they also come in capsules too. And you're not supposed to open the capsules and crush them.
I seen a medication card where you tell they got a little red label that they do not touch.
And then doesn't give you any more information. You're like, why? You're like a child. I need to touch it. What's wrong with this pill? It's true, but you don't live in the perfect world. And if you were in the hospital, you would be more educated than you are in long-term care. And it's a sad thing. But it's just to go to show you, because you'll be in the hospital, for example, Christian Northeast, and you'll be prompted on the EHR. Are you going to apply nitrate gloves? Are you wearing a gown? And you have to answer these questions once you scan that drug, right? And it prompts you to do all these things. But in long-term care, you're on your own.
Yep.
I know it.
I used nitroglycerin tablets before. That's why I'm saying I didn't know it's good now. I get pinch dry every day and they never know.
You know what? We care about you. I'm trying to teach you. I'm trying to tell you, and I'm not trying to toxify your mind. So the evaluation part is, because there could be a lot of side effects, okay? Gynecomastia, which is male breast enlargement. That could be one of the side effects.
What's it called?
Gynecomastia.
Oh,
Man boobs.
yeah.
So you would tell your man that when he left the office, right, that you might develop man boobs? No, if he comes back and he has them, oops, that's a side effect. Why didn't you tell me? I looked it up when you got here. It's going to decrease the inflammation of the prostate, and it's going to help with that urinary retention if they're having it. Could it cause orthostatic hypotension? Yeah. Let's look at this one too. This is another selective one, alpha-1 blocker. And then so you've got tamsulosin, which is Flomax, alfuzosin, which is uraxatrol. So same thing with these. These are also labeled your anti-neoplastic type of medications, your chemotherapy drugs, and they'll tell you not to crush the contents. I know you're like, oh, I'm so glad I'm going to class now. What are the side effects? Here you go. You can decrease libido. It's supposed to bring down the inflammation of the prostate gland.
I didn't know this about it.
Yeah, and more so when we're talking about your PERS scar than any of them. But nonetheless, what is the evaluation? It's going to help relax the smooth muscle tissue. It's going to decrease the inflammation of the prostate gland. It's going to allow a male to effectively urinate without urinary retention. What are the side effects? Imagine that. Hypotension. Let's see, it's an alpha-1 adrenergic blocker, and alpha-1 refers to the heart. Because there's alpha cells and there's beta cells in the heart. So remember, beta-1 refers to the heart, alpha-1 refers to the heart too. What happens if you have an overactive bladder? This is the women that are constantly wearing those pads, right? So the problem is the bladder is having spasms. And it doesn't matter if it's full or half empty, it's just going to let go of the urine because it loses its elasticity. So then you have women who are incontinent. A physician may prescribe to them ditropan or detrol, and these are urinary antispasmodic drugs, and they're going to help decrease that spasm in the bladder and help hold the urine better.
This only happens to women?
No, it happens to men too. Men also get on this drug, but women are usually the primary ones because I guess the childbearing and all the changes inside of our body. So now with this, there comes a lot of other problems. This can come in an oral agent and it's usually extended release. You can't crush it. Or it comes in a patch and we tell you apply it to your hip, your abdomen, or your buttocks. Now, it's going to help improve the incontinence, okay, by relaxing the bladder muscle so that the muscle can feel when it's full or when it's empty. One of the biggest side effects is it could cause it to be urinary retention. Oops. And before I leave this, I have to tell you, make sure that you tell your patient not to get overheated because this has a cholinergic type of side effect that it dries everything up and it causes them not to perspire. So they don't recognize when they get overheated and they could actually have a stroke. So we try to tell these patients to take this med, not to expose themselves to extreme heat. And it takes away that ability to sweat. Pyridium. Have you heard about that one? You buy it over the counter. Patients that frequently have urinary tract infections will be prescribed Pyridium. They're only taking it twice a day for about 2 days. We don't like for them to take it more than 3 days. And it's going to help because it's a little bit of a urinary anesthetic. It's like giving the bladder an aspirin. in that it helps with that discomfort that they feel with the frequent urination. So it's going to help decrease the pain in their urination, because you know when you have a UTI, how you burn. It's going to stain the urine red orange, and the clothing and the toilet and everything else. That's one of the biggest side effects. You got to increase the fluid intake for your patient for the entire day. 2 slides. Desmopressin, also known as DDAVP. It's an antidiuretic hormone. It's given to patients that have bedwetting problems. Bedwetting is also referred to as enuresis. Do you know anything about diabetes insipidus? It is an imbalance in the pituitary gland. Okay, it's not diabetes at all, but there's like 4 different types of diabetes insipidus, but all 4 of these types cause a lot of urination. So like where you would normally urinate about 4 quarts a day, your body, if it has diabetes insipidus, will urinate 20 quarts a day. And so if I urinate 20 quarts a day, what can that do to me? And balance my electrolytes, right? Yes. So patients that have diabetes insipidus will also take this drug to help prevent that urination. So of course, besides the fact of teaching them not to take any over-the-counter herbal remedies, make sure that they also limit their fluid intake before bed. Both the patient that has diabetes insipidus or the patient that has enuresis. We're going to go back and we're going to see that there's a decreased frequency of nocturnal enuresis and a decrease in polydipsia. What's that? Yes, exactly. And then, of course, here are your potential side effects. So what I'm going to do is I'm going to end this. I'll divide it up. I'll post it. And then I'll send you guys an email to let you know when it's there. Okay. Have a great weekend. No, I'm going to open it right now. I'm going to open up the pre-exams.